Now, in a slight change to our schedule, we have got Barrett, who is going to talk to us briefly about our amazing MSc in global mental health. Thank you very much, Barbara.
Hi, good afternoon, everyone. I've just been asked to say a few words. Unfortunately, Ritz Kakuma is not able to be with us today as the programme leader at LSHTM. But I just wanted to start, and everyone's been sitting for a while after lunch. Could anyone who is now an MSc student in global mental health or has been in the past, could you stand up so we can all see how many of you are here? Brilliant. Now, can you stand up if you teach on the programme or if you supervised a student or helped run it in any way? Could you also stand up? Okay, so we've got more than half the people standing up in the room, I reckon. Thanks very much. You can all sit down now. I just wanted to do that just to show physically what a fundamental part of the Centre for Global Mental Health, the MSc programme, is. So the programme's now in its 8th year. We have had students from 54 countries in the world. 70% of our students are from overseas, and 30% of our students now are from low middle income countries. And you can see a very pleasing graph in our handout here today, which shows that the numbers from low income countries are increasing. And that's because of all the research that we're doing out in the world, and also that we have been trying really hard to get properly funded places and scholarships and studentships for students who come to us from overseas. So what do we do on the programme? I think we do one thing, we do it very well. We teach students to initiate, develop and evaluate mental health programmes in low resource settings. And when students leave us, as they do after only a year, they go on to contribute to research, to policy and to practice. So our students go and work in government, they go and have academic careers. Caroline's one of our students, she's here talking about her PhD earlier. They go and work in NGOs. We have students at the World Bank, at the WHO, all sorts of places. Importantly, we also have a number of clinicians who come and study with us, and they go then and they take that back to wherever they've come from, wherever their home is, and they take back those concepts of initiating, developing and evaluating mental health programs, and they take it back into their practice there. Thinking about the teaching that we do and the capacity building that we do in the context of the Centre for Global Mental Health, I think what I've learnt over the years of being involved in the programme is that it's a two-way thing. Our students learn from us, but probably equally and most importantly, we learn from our students. Our students challenge us to improve the way that we teach and communicate. And probably most importantly, our students challenge us to think about global mental health in new ways. We have had awkward and difficult and challenging conversations as part of teaching, which is exactly how it should be. Because ultimately, I think the teaching and the capacity building that we do challenges us to do better research in global mental health. So just going to make those students stand up again one last time at the end, and we're going to give everyone a massive clap. So thanks very much.
I don't know what I'm doing with an orange in my hand, but anyway, I didn't have a chance to have lunch. It's my great pleasure to invite our head of department, actually. Is our next speaker. And Craig, who is a distinguished epidemiologist in mental health. It's kind of sort of going to talk to you about something that we haven't really touched much during the day, and it's the other side, the severe mental illness in low and middle income countries. Please, Greg.
Thanks very much, Ricardo. It is a real pleasure to be here and to share in the celebrations of the really remarkable success that the Centre for Global Mental Health has had over the past 10 years. As Ricardo said, I'm going to talk about psychotic disorders. And something that I think it's probably not too unfair to say that the movement for global mental health has not engaged with psychotic disorders to the same extent that it has others. Of course, it's not possible to do everything simultaneously, but I do think that there is virtue and value in a focus on psychotic disorders. I'm going to do three things. I'm going to talk about the heterogeneity of psychotic disorders in general. I'm going to then try to put that within a global perspective. And then I'm going to talk a little bit about a program of work that we've got ongoing, which is attempting to try to understand in a global context more about the kind of origins and sources of the heterogeneity that we see in psychotic disorders. And the reason for this, I think, is fairly straightforward. If we're to develop humane and effective services that are both accessible and acceptable to people in local contexts, we need to understand something about the drivers of the variations that we see in the presentation, in the onset, in the course and outcome of psychotic disorders, in a wider range of settings. We can't simply assume that what we know about psychotic disorders from studies in high-income countries can be translated and transposed into other contexts, and that what we know about interventions and so on can be translated and transposed into these contexts in simple and straightforward ways. So we need another level of understanding around psychotic mental disorders. To just give a kind of brief bit of context to this, psychotic disorders as a whole, and here I'm talking about all disorders in which psychotic experiences such as hallucinations, delusions, disturbances of thought and so on occur, they're more common than we might think, around about 3% for lifetime prevalence. Incidence of all psychotic disorders about 20 to 30 per 100,000 per year. Average age of onset is also a little bit later than you might imagine from the textbooks, around about 30. The outcome we know is highly variable and difficult to predict. There's a high level of comorbid physical health problems amongst people with a psychotic disorder. And these disorders are a source of enormous suffering and burden for individuals, families, and for wider society. Fewer than 20% of people who develop a psychotic disorder sustain long-term employment. And this is not solely a consequence of the disorder itself. Graham's talked about stigma, and I think this is one of the key drivers of why it is that people struggle to reintegrate back into the economy following an episode of psychosis. And the cost to society, both in terms of care and the loss that occurs because of lost productivity and so on, is vast. In the UK alone, around about 7 billion per year. And what we also know is that those with a psychotic disorder have higher rates of mortality than those without a psychotic disorder. And this slide shows data from a study which was a long-term follow-up study of a sample of people with psychotic disorder in South London, Nottingham, and Bristol in the UK. And what we found in this follow-up is that those with the first episode of psychosis, 12 years later, died at a rate which is about 3 times that of the general population, but particularly high for non-natural causes of death. And to put that further into context, some people with a psychotic disorder die on average around about 10 to 20 years earlier than those without a psychotic disorder. So I hope it's not, I hope it's clear that this is a major social and public health issue, and one that deserves attention. So what I want to do now is I want to talk about psychosis in general. So what do we know about psychotic disorders? And there's a certain sense in which our understanding of psychotic disorders has transformed over the past 15 to 20 years. What we do know is that they're very varied in their manifestation, incidence, and so on. Up until about 15 years ago, what we knew about the occurrence of psychotic disorders in populations was derived largely from this study by the World Health Organization, a 10-country study looking at the incidence of first episode psychosis across 12 sites in 10 countries. And the conclusion that was drawn from this and has dominated and has been repeated in textbooks ever since is that the incidence, the occurrence of psychotic disorders is fairly uniform around the world. And the basis for this was simply that there was no statistically significant difference in the rates. But if you look, actually, there's a twofold variation in the incidence of narrow schizophrenia from Aarhus to Nottingham, 7 to 14 per 100,000, and even wider variation in broad schizophrenia. So the conclusion in the first place was somewhat misleading. But there were also several methodological issues with this type of work, which also potentially impacts on and reduces the heterogeneity that was observed. And one of which is that the case finding, the identification of individuals with psychosis, was done primarily through health services. And many of you will be from countries where the availability of healthcare services for people with psychosis is very scant, and will know that if you use those services, you're going to miss lots of people. And then using that as a basis to estimate incidence is problematic, clearly problematic. What we've known since, and what's accumulated since, is a whole body of research that demonstrates, I think, fairly conclusively and convincingly that the incidence of psychotic disorders varies really quite markedly across populations and across social groups. And this is a summary from the most recent meta-analysis of this by Hannah Jongsma, showing that if you look overall, the incidence is around about 26 per 100,000, but that summary figure, and I'm slightly suspicious of these kinds of summary figures, it obscures and hides behind it considerable variation. Rates tend to be higher amongst men. They're certainly higher amongst people from some migrant and minority ethnic populations. They tend to be higher in cities, something that I'm going to return to. But also, interestingly, they vary by study design. And so the more complete the coverage and the use of population registers, the higher tend to be the rates of psychotic disorders. In relation to the findings on urbanicity, we did a study in 5 European countries and compared within each of those countries the rates of psychosis in urban and rural areas. And interestingly, what we found is that the incidence was elevated in northern European cities, to put it crudely, but not in southern European cities. And in southern European cities, the incidence was comparable with what we found in northern European centres. So I think this is a kind of warning about extrapolating from studies in high-income countries in a select number of centres in the UK, North America, and Australia to the rest of the world. On the back of all this kind of work that's showing that there's variations in the incidence of psychotic disorders, it's kind of stimulated a lot of interest in what might be the underlying etiological explanations that drive these kinds of variations. And our understanding of the etiology as kind of psychosis has really expanded and deepened over the past 10 to 15 years. And what we now know is that psychotic disorders are the outcome of a complex array of risk and protective factors that in different combinations impact on individuals in different sorts of ways. And so what you have is multiple pathways, multiple sufficient clusters of causes that lead ultimately to a similar kind of endpoint of psychotic disorder. And amongst those, that kind of array of complex factors that push people along pathways to psychotic disorders, it's become clear that there are several social structural factors that are important in the onset of psychotic disorders, and these occur at population levels, so from population density, area level deprivation, and so on, through to individual level exposures and experiences, in particular early trauma, and other kinds of events which particularly involve threat, violence, and hostility. So the calls that there have recently been, and I think Crick mentioned this this morning, to begin to consider and think about the kind of social drivers and social determinants of mental health within the global mental health field, certainly is true in relation to psychotic disorders. But not only that, it seems that these kinds of variations in the underpinning kind of etiological factors that drive onset do also lead to quite varied manifestations of disorder. So if you look at any group of individuals with a first episode psychosis, there's really quite a wide array of different kinds of experiences. And these overlap with and cross over diagnostic boundaries. So I'm not entirely sure if this will be easy enough to read, but essentially what you have is a kind of grid showing dimensions of psychotic symptoms and experiences. And across all diagnostic groups, there's a wide variety of these kind of clusters, these dimensions of experience. And when you look at particular kinds of risk factors, say, for example, early trauma or cannabis use, these tend to relate to different types of, or specific types of psychotic experiences. And so it seems that there is some kind of specificity for the kinds of experiences and the drivers of onset and the manifestation of psychotic disorders. And then from that perspective, it becomes more important still to try to examine how this operates and how this is manifest in different social and cultural contexts, because the manifestation, the form that disorder takes, will also say something to us about the way in which it should be treated or responded to. And so we can't assume that globally psychosis and psychotic disorders will look the same, or that there'll be a similar manifestation across a group of people with psychotic disorder. This kind of variability also extends to outcome. This is showing findings again from the study that we conducted in 3 UK centres, following over the long term a group of people with a first episode of psychotic disorder. And there's quite wide variation in the symptomatic course and outcome of psychoses. A substantial minority, around about 20% to a quarter, experience near continuous symptoms. Many of these individuals appear not to derive any kind of benefit from antipsychotic medications and so on. But the flip side of that is at 10 years, around about 50% of the sample symptomatically recovered, and that means that they've been symptom-free for a period of 2 years prior to the follow-up, which suggests that actually there's a more varied, but also in many respects, a more positive trajectory for psychotic disorders for many people than is often assumed. So that is a very kind of quick potted sort of tour of what we currently know about the kind of epidemiology of psychotic disorders. All of what I've talked about so far is 90% of the work has been done, 90+% has been done in high-income countries, in select centres in the UK, certain parts of Europe, in the US and Canada and in Australia. So it begs the question, what do we know about psychotic disorders elsewhere? What do we know about psychotic disorders in the rest of the world, in the majority of the world's populations? And the answer is actually not very much. So to take, for example, the World Health Organization studies from the 1970s and 1980s, if you actually look and consider what sites were included and from what sites we could derive, for example, information about incidence, there was actually only one site on which there was high enough quality data to be able to estimate incidence rates in that study in what we might broadly refer to as a low middle income or developing country. And that was to an urban and rural site in Chandigarh in India. Massive leaps to extrapolate from this to the conclusion that there's a uniform worldwide incidence of schizophrenia. And in fact, if you look beyond that study, we did a review as part of the study that I'm going to talk about, and there are actually very few studies, high-quality studies, of the incidence of psychotic disorders in contexts outside of high-income countries. This shows some of those studies, and they're highly methodologically variable. And the problem here is that because of the methodological variation, we simply can't know whether the variations we see in the rates is a true reflection of population differences or just simply methodological artifact of the way that the studies have been conducted. And just a further point about the danger of extrapolating from research in high-income countries and assuming that this is a universal across all populations. Recent work using data from the World Mental Health Surveys suggests that, in fact, if you look at the association between urbanicity, city living, and psychoses in again, broadly speaking, developing or low middle-income countries, there's no evidence of association. So it seems even more so that what we thought was this urban effect that was the most replicated in the epidemiology of psychoses and was universal is in fact something that's select and specific to Northern European contexts. And that begs important questions about what actually is driving variations in rates. What we know about the etiology or risk factors for psychotic disorders in low middle income countries is next to zero. There have been very few studies. What we know about the variation in the presentation and phenomenology of psychotic disorders in those settings is equally next to zero. We know very little. But one finding from the WHO studies that seems to have stuck is this finding reflected here that outcomes are better in developing countries compared with developed countries. And what this slide shows is essentially that the positive outcomes are about 50% more likely amongst those from developing country settings compared with developed country settings. Now, this begs all kinds of questions, all kinds of challenging questions. But it's nice actually to have so many people from the MSc here, both past and present. And I think what I'm going to say now is something that I'm sure I've said already, and so it's a nice chance to reiterate it again, is before you move to substantive explanations for what's going on, what are the methodological issues that might explain these findings? So could there be variations in sampling across these sites which lead to these kinds of differences? Could those with better outcomes be being retained in the samples more frequently amongst those from developing countries? And one possibility here, and this comes really from a review of the wider literature that Alex Cohen completed, is that in those countries that appear, in those sites that appear to have better outcomes, they also have higher rates of mortality. And of course, those who have died are not included in these kind of outcome analyses. So one indicator of the possible explanation that might go beyond, or which might suggest that there's something methodological in the way that these studies have been done in explaining this kind of difference. Now, my interest in this area, and I'm going to finish by talking a little bit about the program of work that we've been doing. My interest in this area really came from a conversation that I had with Alex in 2007. And I remember this because I was at Harvard on a fellowship, and I joined, I'm not going to say the department. I joined the department, and I sent an email around to everyone in the department saying, hello, I'm here, it'd be really interesting, great to meet, hear about your work. And I got one reply, and that reply was from Alex. And we had a conversation, and anybody who's had a kind of more than a 5-minute conversation with Alex will know about this problem of the better outcomes in developing countries. And so we developed from that a program of work. And I should also say as well that Alex was instrumental in the development of the MSc, and I think in the context of congratulating everyone for their contributions, I think in his absence, Alex's contribution to that should be acknowledged. But we developed from out of this kind of collaboration, this program of work, which is essentially 3 phases. And it is centered in 3 countries, in India, in Nigeria, and in Trinidad. And the first phase is a kind of pilot phase. So mindful of all the kinds of methodological issues and challenges that there are, we're trying to investigate and study psychotic disorders in global context, and the challenges of doing cross-country and comparable work where you can be certain that what you're seeing is differences that are actually true reflections of what's going on and not methodological artifact. Our first step was to conduct a really quite extensive pilot and feasibility, a series of pilot and feasibility studies designed to establish whether or not we could actually do this. Could we identify a broadly representative group of individuals with either a first episode or an untreated psychotic disorder without having to rely on mental health services? Could we also identify a representative sample of controls? Very few studies in these settings of psychotic disorder have used the control comparison group. And then would we be able to follow people over time while minimizing attrition in order to be able to kind of answer questions about long-term follow-up or even short, medium-term follow-up without that being influenced by issues around the attrition and so on. So this work has been done in catchment areas, in sites in Chennai in India, in Ibadan in Nigeria, and in the northern parts of Trinidad. In the pilot work, we had populations at risk, aged between 18 and 64 of around about 250,000. And our initial step was to see, can we identify individuals with a psychotic disorder? As I said, most of this work focuses in on mental health services, but we wanted to extend out into and see whether we could identify individuals from who received care from traditional folk healers in these settings, but also into the communities using key informants. So the first step was to establish a really quite extensive detection system to try to identify all individuals who met our inclusion criteria. In the pilot study, over the 6-month period, 6 to 7 month period, we identified between 35 and 64 in Trinidad and India. And this next slide just shows, and I'm slightly conscious of time, so I'm kind of tripping through this a little bit, is just to give you a flavour of what we found from the pilot. And a couple of things to note, and this is in relation to age, that the age of onset, or rather, sorry, the age of contact at this point is higher. This is partly a reflection of the duration of untreated psychosis in India relative to Nigeria, relative to Trinidad. And the gender distribution is also interesting. We assume that the 1.4 increased incidence amongst men, again, is universal. Maybe it's not. Most of the people, apart from in Trinidad, which has services which much more mimic and are similar to those we find in the UK, came through non-mental health services. In terms of incidence rates, found rates in India, 46 per 100,000, in Nigeria, around about 31 per 100,000, in Trinidad, around about 44 per 100,000, all consistently higher than had been previously reported in systematic reviews. This slide just simply shows the kind of differences in the age and gender distribution of the incidence rates. We typically see a kind of a peak onset around about late 20s, and then a decline thereafter with a small increase, particularly amongst women in kind of around 30 to 40. But you see a very different distribution here in these. Of course, this is pilot data, and so we need to take with a pinch of salt these findings, but they do hint at interesting things going on and the value of trying to understand what's going on in particular and local settings. And so the second stage of Intrepid is extending this into full program of work in extended catchment areas, looking at incidence, presentation, all the things that I've talked about, to your outcomes, help-seeking impact of psychotic disorders in these settings, but also physical health problems. And so there's a lot of work at the moment about the physical comorbidities that there are with psychosis, but the kinds of physical comorbidities that there might be in developing countries or low-middle-income countries may well be very different from that we see in high-income countries. Our goal being in each site across each site across all sites to generate a sample of 720 individuals with the first episode, who we would then follow over time, a comparable group of controls, and to collect extensive information on those. As you can see here, just a kind of flavour of the type of information that we want to try to collect from individuals. This slide gives you a bit of a flavour of the sample characteristics. Again, interesting variations by age and by gender. The samples tend to be older than we typically find, which might be partly a function of duration of untreated psychosis and so on. In relation to incidence, what we're finding in the main program is that the incidence rates are somewhat lower, particularly in India and in Nigeria. And some of that may be an artifact of the fact that we were initially in the pilot study effectively kind of mopping up people who have been unwell for some considerable time in local populations. But we nonetheless see a similar kind of pattern where the highest rates in Trinidad, lowest rates interesting in Nigeria, and this is a very, very densely populated area in Nigeria. And just the final bit is, as you see high rates in Trinidad, what we actually see is overall psychopathology or severity of symptomatic presentation is lower or lesser in Trinidad. So the scores here, the higher the score, is effectively the lower the symptoms. And so we have this kind of situation where the lowest rates, we have the highest, the greatest severity, and where there's the highest rates, we have the lesser severity. So, to finish, there's marked heterogeneity in incidence presentation by place and social group of psychotic disorders. But that when we extend our gaze more widely, the patterns become more complex still, and there's even greater inconsistencies. What we know so far has been based on a remarkably narrow range of settings, and so there is much that we've got to learn about the sources of heterogeneity around the world, and this is the basis. This has to be the basis for developing humane and effective, acceptable responses in diverse settings. But to do this, we need robust methodological studies, which are challenging to do. And our next step, and to finish on this, our next step is to try to expand this even further. There's work ongoing in South Africa led by Jonathan Burns and colleagues in South Africa, extending the work that we're doing here to another setting. And our goal is to try to do this even more so, and to establish a kind of global consortium which will really create the infrastructure for sustainable work on psychotic disorders globally. And if you want more information, then you can find, we have a website. And to finish by thanking all the people who have been involved in doing this. It's been mentioned a few times, but all the hard work in this kind of research is done by people on the ground, the teams in India, Nigeria, and Trinidad. Thank you very much.
I think we probably got time for a couple of questions or comments. This one here. Rosanne.
Just from my clinical experience of being a registrar on a South East London female acute ward, where many of our patients were from African countries, my sense from them was that perhaps some of the very severely unwell people with severe mental illness, if there's any connection to the UK or a high-income country where perhaps healthcare is more comprehensive, may be facilitated to migrate by caring family members who feel like their needs aren't met in that country. But then I feel that impression was probably confounded by all of the suffering and additional difficulty associated with being mentally ill in South East London when you're not from here. And I don't know how we would do the research to answer whether that's a meaningful factor in this issue.
Well, a couple of things. One thing we know that rates of psychotic disorder are higher amongst people from migrant and minority ethnic groups in certain contexts, in Europe, for example. But there have been some studies. So there was a study looking at this in Uganda, where they looked at a group of people who were preparing to migrate. And actually what they found is that those who had kind of and this is the crude ways of talking about this, but kind of the pre-morbid traits or early indicators of psychotic experiences, they're the ones that are less likely or less able to be able to migrate. So I don't think that the higher rate that we see in this country is really a function of that kind of process. Of course it may happen, but I don't think it's something that would be a major explanation for why we see high rates. And I think the other possible thing to say about that is it certainly when you do this kind of work in these sorts of settings, what's needed to be able to migrate is such that it's often well beyond the means of the individuals. The majority of individuals that experience these kinds of problems in their families in those contexts. So again, I mean, you could certainly begin to try to look at to what extent that was an issue, but I suspect it's a relatively minor issue.
Hi, Craig. Thanks for a great talk. I was really interested in what you were saying about the social and structural drivers of psychotic experiences and wondering if there's opportunity within Intrepid to test social causation and social drift pathways, in the bidirectional relationship between poverty and psychosis, and whether you're exploring that.
Well, we're collecting relevant data. But I think the challenges that we face in this study, as in all studies of psychosis, is that it is, as you know, phenomenally difficult to disentangle cause and effect. When you've got a disorder which impacts on people's social worlds and social lives, and where you've got study designs that you can only use where you've got people who already have disorder, because a longitudinal follow-up study, a long-term cohort study, to detect enough people with psychosis is just too expensive. And would take too long. So I think what we can do in the context of Intrepid is we can establish whether the kinds of social drivers that we see in high-income countries are relevant in these settings, or whether there are other kind of social drivers. But whether we'll be able to then take the next step and say that these are causally linked, I'm not so sure.
Okay. Thank you so much, Craig. So we're going to have a little kind of break. There will be coffee there for you and tea, so that you can enjoy the posters. Let me remind you that those people who were selected to present or have their posters in there were lots of people who wanted to do this. So there was, tough competition to make it. So please do enjoy the poster, have a cup of coffee. After that, we have a couple of really interesting talks changing from what we've been discussing, HIV and aging, and then we're going to have a round table and to end with the very wise words of Richard Horton. So please enjoy your cup of tea.